less than or more than 1 millimeter of asymmetry, 1.5 millimeters of asymmetry is something that's going to be noticeable. And so, that's the type of thing that we want to correct. Number two, we want to maintain pupil clearance. This is a functional aspect of the surgery, so that people can see clearly and be able to not have their visual field cut off, right? So we want to restore pupil clearance. Of course, there's variability in the population, but around 2.5 millimeters is a pretty good average. Number three is that we want to do this with elevating with the appropriate contour, so that we don't create abnormalities in the contour of the eyelid, which can draw the attention away from concentrating on an individual and looking at their pieces of their eyelid. And finally, we want to manage upper eyelid aesthetics, because of course the ptosis itself is just one aspect of the upper eyelid continuum, which can reflect the brow position, dermatoclasis, and others. So keeping these four goals in mind, this is kind of a way of thinking about and approaching ptosis management. So what are our surgical options? There's two main surgical options that we think about: the anterior ptosis and the posterior ptosis. Of course, we're mostly talking about involutional ptosis here, and not congenital or myogenic or anything like that. We're really talking about just your average run-of-the-mill involutional ptosis. Both of these options are pretty good. Under most circumstances, the results are pretty good for both external approaches and internal approaches. With the external approach, this is the classic approach. Of course, there's been hundreds of modifications over the years, anterior to posterior, posterior to anterior, white line advancement, resections, and advancements, all of these different types of techniques. They really show about the same efficacy. You end up with around a 3 millimeter post-op MRD1, and the reoperation rate, varies, but on average around 8.5% for external levator resection. For MMCR, or a posterior ptosis surgery, again, you can achieve basically the same results, around 3.1 millimeters post-op MRD1. The reoperation rate tends to be a little bit lower, but of course that's a bit of a flawed outcome. So I consider them pretty similar, that you're going to have around 5 to 8% reoperation rate, and about a 3 to 3.5 millimeter post-op MRD1. Symmetry, pretty good overall. I think that we tend to overestimate how symmetric our results are, but if you look in the literature, you see that kind of symmetry is really found in around 75% of cases. We can also use this in combined surgery. So, a lot of people in the past, it was historically thought that anterior levator resection was really the best surgery to combine with blepharoplasty, for instance, but posterior ptosis surgery can be combined with blepharoplasty as well. And additionally, you can use posterior ptosis surgery with multiple different types of pathologies. You can use it with poor levator function, contact lens related ptosis, congenital ptosis, ptosis in glaucoma patients. And so over the years, there have been a number of publications showing that all of these different pathologies can be managed with posterior ptosis, as classically we had thought of only for anterior ptosis. These are my cases. I've done all of these things, and they all work variably. Nothing perfect, but they all work pretty well from posterior or anterior. However, nothing is perfect. We do have some failures. The external levators tend to overcorrect, while we tend to see undercorrection with the posterior ptosis. You do get a slight amount of lateral peaking in external levator resections on average, and which you don't see in the posterior ptosis. So that does account for some of the reoperations. However, both have reoperation rates. The external levator tends to be too high, and the posterior ptosis tends to be too low. But you have to remember that the eyelid is not isolated, it's seen in context. And so when we're managing ptosis, we're actually managing the whole upper eyelid continuum. And this consists of the eyelid margin itself, which we've been talking about in terms of MRD1, the eyelid brow junction, and then the brow fat, and then the brow. That's the whole upper eyelid continuum, and all of these different elements are interconnected with each other. Particularly when we talk about the eyelid margin, it does have effects on all the other aspects of the upper eyelid aesthetics. These are interdependent elements. These are four main ways where we can see the interdependence of ptosis with the other elements of the upper eyelid continuum. In terms of unmasking dermatochalasis, in terms of reversing brow elevation or causing it, bearing the superior sulcus deformity, and then abnormalities of the eyelid crease. And we'll go through each of these. So dermatochalasis, the issue here is that because patients have a low eyelid and a high eyebrow, the space between the eyelid and the eyebrow, which is where the eyelid skin persists, is elongated, stretched under normal circumstances. And then by elevating the eyelid and possibly by lowering the eyebrow, that skin becomes unmasked. It was there the whole time, but it becomes unmasked. How can we recognize that this is going to happen? Well, you could measure the interlamellar length. You'd expect the interlamellar length to be around, under 25, maybe up to 30. But if you measure preoperatively and there's an interlamellar length that's beyond 30, 35, they're going to have dermatochalasis after surgery once you elevate that eyelid. So that's one way that you can recognize it. You can also lower the brow and observe. And so by pushing the brow down, either manually or with Botox, you can see what's going to happen after ptosis surgery, where you might see that reduction in the brow position and the folding of the eyelid skin back into the eyelid after ptosis surgery. So that's another way that you can identify the dermatochalasis. And what can you do about it? Well, you can do combined surgery. Doing blepharoplasty and ptosis surgery simultaneously. This can be both asymmetric or symmetric, and sometimes doing it in a staged way, it can even be more reliable. So you work on the ptosis first, unmasks the dermatochalasis, knowing that in advance, counseling the patients in advance, and then doing the blepharoplasty after when you have a better sense of what exactly it's going to look like. So sometimes, you can even just do a blepharoplasty alone. There's dermatochalasis there and a mild amount of ptosis, you can get about 1 millimeter of MRD improvement just with blepharoplasty. So, recognizing that there is dermatochalasis there that's being hidden or disguised because of ptosis and or brow elevation, noticing that in advance, counseling the patients, and either doing simultaneous surgery or sequential surgery, or even just blepharoplasty alone. The superior sulcus, so again, when you have that elevation of the eyelid, of the eyebrow, the lowering of the eyelid with the flattening of the eyelid crease, especially in an older patient that may have periorbital fat loss, you can really get this bearing of the superior sulcus. And you kind of create that old 90s blepharoplasty look with the A-frame deformity and that skeletonization of the eye that's, it doesn't really look that great, it's not that popular. But of course, the ptosis surgery can change those relationships. So first you need to recognize that this is going on. A couple ways you can do that. You can see a high crease or a flattening of the crease. Sometimes there's no crease at all that's really noted. Once you do the ptosis surgery, that crease may show up. A low MRD1 can be another indication of that there is ptosis there, and you can see that stretching of the eyelid. And brow asymmetry, sometimes if there's one side shows that superior sulcus and the other side doesn't. So that brow asymmetry is really going to tell you that there is a possibility that could change after ptosis surgery. And then this medial fat prolapse. Now often people have medial fat prolapse. However, if you really see a prominent medial fat prolapse kind of coming underneath the rim like that, that could be a sign that the superior sulcus is artificially hollowed because of ptosis and or brow elevation. And so what can you do about this? Well, ptosis surgery actually helps with this problem. You don't really have to do much. So by doing the ptosis surgery, allowing the brows to relax, that can actually fill that superior sulcus. So, a patient may come in looking for some solution for this skeletonized superior sulcus, and often the ptosis surgery is all you really need to do. Finally, you could consider post-operatively, after the TOSA surgery, you could consider putting in fillers and or fat injections along the inferior brow, and that helps to fill that space. Particularly in Asian patients, they can really tolerate that quite well because they don't naturally have that curvature, and accepting a little bit of swelling or edema in that region can actually smooth that contour out. So you can manage that with fat injections, or I prefer hyaluronic acid under most circumstances. What about the eyelid crease? So the ptosis, we know that ptosis can lead to a higher eyelid crease, and that by doing ptosis surgery, it actually can lower the crease, or at least move it back to a more normal position, and that can change the TPS, or the tarsal platform show. So it changes how much of the tarsus can be seen underneath the crease. So how do we recognize if there is a crease, if there is a high crease? Well, one is crease asymmetry, so you have two different creases on each side. That's a good sign. And then you could also measure it, looking at more than 12, 12 or 15, might be reasonable in certain ethnic backgrounds, in a non-Asian eyelid, whereas in an Asian eyelid, anything higher than 7 would be pretty unusual, unless you're talking about like mixed race eyelid, in which case it could be highly variable. But in a standard or classic Asian eyelid, you're going to expect that crease to be below 7 millimeters approximately. And here's just a couple ways you can measure that. And how do you manage that? Well, asymmetric ptosis surgery can help with that. So ptosis surgery on the side of the lower of the crease abnormality can help to balance out those creases to create greater symmetry. Or you can do either concurrent or sequential crease formation. And I've done it both ways. Definitely sequential crease formations are going to be a little bit more reliable because you have a better idea of exactly what you're looking for. Whereas if you have one side that has a very good crease, doing concurrent crease formation, that's reasonable as well, because you kind of have a model already in one eyelid that's really going to tell you what to do on the other side. And finally, brow elevation. So we talked about this a number of times in superior sulcus deformity and in dermatoplasis, that sometimes ptosis leads to a higher brow. Not all the time, but sometimes. And sometimes the ptosis surgery can actually cause that brow to come back down, and it will unmask that dermatoplasis, and of course it can also protect or help with the superior sulcus deformity. But the problem is that not all elevated brows are elevated because of ptosis. They could just be elevated for a number of different reasons, not the least of which is dynamics or personality. So what are ways that we can recognize? Number one is you can look for dynamic and static frontalis rhytids. So if they have asymmetric brow elevation, particularly you see rhytids in the frontalis over the asymmetrically elevated brow, then that's probably an elevated brow. Bilaterally, if they have very, very deep static frontalis rhytids across the entire brow, that could be a sign that they're elevating their brows. You can also ask them to elevate their brows and see if they can elevate them any more than they already are. So just by asking them, so elevate your brow as high as you can, and then you can kind of measure in those two positions. You can see that when we elevate the brow as much as possible on both sides, that actually the right side doesn't really elevate that much anymore. That's a statically elevated brow. You can also use phenylephrine testing, which can sometimes relax the brow, but unfortunately it's not completely reliable about that relaxation. And then how do you manage that elevated brow? Well, ptosis surgery, it doesn't work every time, but somewhere around 15, maybe 20% of the time, that brow will come down with appropriate ptosis surgery. Unfortunately, it's not really that predictable. You can say that if you use the phenylephrine test, that if the brow does not relax with phenylephrine test, it's probably not going to with surgery. But if it does relax with phenylephrine testing, then at least it has a chance, but it's not completely predictable. What else can you do after surgery? Well, you could consider doing postoperative chemodenervation. So basically Botox to the brow. And sometimes after you've done the ptosis surgery, you can retrain that brow so it does get into a more normal position. So that's always an option after surgery. I often counsel patients before surgery that might be something they're going to do after surgery. So we've looked at a number of different things in this talk. We know that our goals of ptosis surgery are to restore MRD symmetry, restore acceptable pupil clearance, and we can do this with either anterior ptosis or posterior ptosis. And in both cases, they work pretty well, but not perfectly, and they can have some reoperation rate, but most people do quite well with either approach. We want to elevate that with an acceptable contour. We know that there is a slight contour deviation towards lateral peaking in ELRs or external invaders. We just want to watch for that and try to maintain that. MMCR is a little bit more reliable in terms of the contour. And then finally, to enhance upper eyelid aesthetics by recognizing dermatoplasis and either treating it concurrently or discussing it beforehand and doing subsequent surgery, recognizing brow elevation, trying to get the brow to go down, possibly even doing chemodenervation after surgery, recognizing superior sulcus deformity, allowing that brow to relax, fill that space with the elevated eyelid, and sometimes adding hyaluronic acids as well, and then by managing the eyelid crease. Ptosis surgery alone or ptosis surgery with crease formation can be helpful in that way. So that's just a short overview of how eyelid ptosis surgery can affect the other aspects of your upper eyelid continuum, and to have some strategies for recognizing those problems in advance, and then of course trying to treat those problems either concurrently or sequentially. I apologize again for not being there in person, and I hope to see you all next year. Thank you.